This is Dr. Rajiv Kishore from Agra, and today we're going to discuss a case and let's see what are the latest drugs we have in hand and how we can help our patients. So, for the record, this patient, Mr. AB, is a 58-year-old patient. He has a history of diabetes for the last 4 years. He's obese, he's got hypertension, dyslipidemia, and obstructive sleep apnea. On examination, his BMI is stable at 32, and his BP is 130/82, and heart rate is 60 beats per minute. His investigation revealed HbA1c of 8.3. That means his sugars are not under control. He's got an eGFR of 70, it's fairly good renal function, LDL of 69, HDL 35, TG 250. He has got hypertriglyceridemia, the typical diabetic pattern, high TGs, high VLDLs, and you got that. Medications, he's on metformin 1000 milligram BD, he's on lisinopril 40 milligram per day, metoprolol ER 100 milligram per day, and he's on statin, atorvastatin 40 milligram per day, and aspirin 81 milligram per day. The patient profile, he has a short duration of type 2 diabetes, he is young, he has no major comorbidities along with no major complication that will reduce his lifespan. He's at low risk for hypoglycemia. He would benefit from a more stringent goal. We can be more aggressive. However, he's also obese, hypertensive, hyperlipidemic, and with OSA, the obstructive sleep apnea disorder. Going by the guidelines, the ADA recommends a very reasonable, less than 7% goal for non-pregnant adults. In addition to efficacy, following considerations predominate in determining the pharmacotherapy for him in such a risk scenario. Because we want to avoid the hypoglycemia, we want to avoid further weight gain, welcome weight loss, and we want to prevent any heart failure or ASCVD or CKD at any cost. And plus, we want the treatment should not be very, very costly. So Mr. AB is willing to start another medication, but it's concerned because he sometimes forgets to take his pills. And he has a fear that additional pills will make him worse. He doesn't want to have injectable. Definitely, we want to be tried GLP-1 RAs, but he was not ready for injections. Since he's scared of taking too many pills, a FDC, a fixed dose combination, may improve the patient adherence by reducing the pill burden. To have less complex treatment regimen, fewer pills, and improved effort profile and more better adherence. People with diabetes commonly live with multiple comorbidities, among which hypertension and cardiovascular disease are the most common, the macrovascular complications. Monotherapy cannot address all these multiple defects and often leads to failure to maintain the glycemic control over time. And if you keep on optimizing, the number of pills will keep on increasing. Current guidelines encourage early adoption of combination therapies, preferably FDCs, so you can attack 2 or 3 different basic pathophysiological processes and improve the basic problem. ADA recommendation is appropriate in high-risk individuals with established type 2 diabetes. The decision to treat with a GLP-1 RA or SGLT2 inhibitor is definitely the choice of the day to reduce the MACE, major adverse cardiac event, the hospitalization for heart failure, CV death, or the CKD, the chronic kidney disease progression, and should be considered independently of baseline HbA1c. So the old concept is gone, where we are only glucocentric. We're just interested in controlling the sugars. But we realized that only by controlling the sugars, by getting a good HbA1c, we were not able to control the quality of life. People were dying early because of other comorbidities, other complications, heart failures, CKDs, metabolic complications. So we realized there's something more to that than just controlling the sugar. So today we have changed the approach and it's no longer glucocentric. It is individualized and we're going for a cardio, metabolic, renal approach. We want to improve the metabolic problems and we want to improve and just prevent the renal and the cardiac complications from happening. And that is the way forward by which we can improve the quality of life. Once you have diabetes, we already know that more than 6 to 7 years of lifespan is reduced. So how to get those years back? That's the only way that you control the comorbidities. And in a country like India, once we get a complication, the treatment is very, very expensive. The patient has to shell out money from his pocket. It's not insurance covered. So it becomes all the more difficult. So it's better, it's being more wiser and explain to the patient, counsel the patient, let him not be penny wise and pound foolish, and let him invest in a drug now and prevent the complications later when he will not be able to get the proper treatment because of the expense and because of the effort involved. So, today we have the empagliflozin combination. The empagliflozin and the linagliptin combination is available as a first-in-class treatment, and SGLT2 inhibitors and DPP4 combination group of drugs. SGLT2, in these inhibitors are a class of novel oral glucose-lowering agents that, apart from lowering glucose by urinary excretion through the kidney, they also have a lot of effects on the heart and the kidney. That's a wonderful part about them. They really now, the recent trials have shown that they have the similar effect even in non-diabetics. You have definitely control, and absolutely you can get a much better results in cases. Long-term mortality improves in cases of heart failure. You have reduction in the MACE, you have reduction in the cardiac deaths and everything. And the empagliflozin is the one which causes drastic 32% reduction in the deaths, the cardiac deaths. It's one of the few agents which is available. Even insulin, can only control the sugar, but it doesn't control the cardiac mortality, it doesn't control the MACE, doesn't control the CKD. So, that these particular drugs, they act independently of the insulin secretion, and they can act at any stage of diabetes. Not that they act only in the beginning or in the later part, they act at any part. You can start in a drug-naive patient, you can start in a patient who is 5 years diabetic down the line, even 10 years down the line. Now, DPP4 inhibitors, they are the incretin-based drugs. They affect the glucose-lowering effect by the elevation of incretin hormones. And these are the only group of drugs which acts on the alpha cells of the pancreas. No other group of drugs acts on the alpha cells. It's unique in that way. And plus, they don't have any weight gain propensity, and they don't have any preposition for hyperglycemia. So they're just ideal for the setup with this particular patient we are talking about. We don't want his weight to increase. We don't want him to go into hypo. We don't want to improve his pill burden. So the combination of these two agents is really wonderful in this case. And the star among all the SGLT2 inhibitors is the empagliflozin, because the empagliflozin trials, the EMPIRE outcome was the landmark trial which changed our concept of these drugs. And 3-point MACE outcome occurred in a much lower percentage, and it was statistically significant when you compare it with placebo. In addition, the cardiovascular safety of linagliptin is well established, and Carmelina trial again further amplified this in spite, and so repeated in the Carolina trial also. The HbA1c decrements with a combination of empalina, either 5 by 25 or maybe 10 by 5 by 10, has demonstrated a 1.81% HbA1 reduction at the baseline of more than 8.4 at 24 weeks in metformin treated groups. The benefits on glycemic control were maintained even after 52 weeks in metformin treated groups, and a higher percentage of patients achieving HbA1c less than 7 were reported for combinations. As you know, in India, the scenario is very bad, and more than 80% of diabetic patients are not at target. It means more than 80% of patients maintain HbA1c more than 7. That's very bad and doesn't have a good effect on the long-term complications. So this particular combination, apart from reducing the pill burden, it offers a suitable component and strategy to achieve the target HbA1c without any increase in the risk of hypoglycemia or weight gain, and also improves the lipid profile. In fact, the weight loss is very important, and also reduce the systolic blood pressure and the diastolic blood pressure. Although the reduction in blood pressure is very minuscule, but over the long term, it has better long-term effects on the macrovascular complications. And a reduction in the genital infections, it was considered by many practitioners something that debarred them from using this group of drugs. The SGLT2 inhibitors in a very small percentage cause genital infections. But when you combine with the DPP4, perhaps because of better glucose control and because of some of these DPP4 enzymes, which are also inhibited along with the DPP4, it also inhibits maybe DPP4, 5, 6, and 7. And because you have better and lesser amount of dental infections when SGLT2 is combined with a DPP4 inhibitor like linagliptin, So when you summarize and looking at all these things, for empagliflozin and a linagliptin combination is a wonderful combination to have all the plus points. It provides a robust HbA1c reduction, that means a good control of sugar, and about 2 to 4 times higher odds of the patients reaching the goals. And plus, both these drugs in trials have shown that the glycemic variability, today, the glycemic variability is another very important thing. It's not only imperative to maintain the HbA1c, but it's also important to maintain a good, the time in range. That's what we call it. Time in range, we call it by, if you have a lot of glucose glycemic variability, then the complications are higher. So these group of drugs, the SGLT2 and the LINA, this combination specifically has been shown to have good effect on the glycemic variability. And that would be very good because our main aim today, apart from first is control of glycemia, I agree, but the main aim today is a safe control of glycemia. Safe control, I mean glycemia control is not associated with hypoglycemia. We don't want hypos. And plus, we don't want weight gain. So if you can have drugs, this particular combination can do it. You have less of pill burden because of the FDC, and you can get good glycemic control. And as a bonus, you're also getting good cardiorenal benefits along with the metabolic benefits and along with other benefits like, you're getting the weight loss and the reductions in the BP. And of course, you can see it reduces the visceral fat and good improvements also in the lipid profile. So looking at all these benefits, I feel today the time has come to shift from the older drugs to the newer group of drugs. Of course, metformin can also always be there. You can have the lifestyle modification and metformin. Whenever a patient comes to us, he's already on metformin and lifestyle, or you can reinforce it. But if he has any compelling indication, I think we should not wait any further and start off this combination of Empalina. Or of course, if he's on some other group of drugs, then if he still feel he doesn't reach on target, then it's never too late to start this particular combination. So we should keep your mind open and use these drugs more and more because they're a wonderful group of drugs giving immense benefits, and we should not deprive a patient of the benefits of these wonderful drugs. As we use these drugs more and more, they are going to get more and more confidence in these drugs, and of course, the patients will definitely benefit. Thank you.